cancer genetics and prevention here at Dana-Farber. And so she can continue to answer some questions about genetic testing if there are any additional questions. But she's going to talk to us a little bit about participating in clinical research. So thank you, Dr. Garber.
Good morning, Terry. Good morning, everyone. Am I coming up? I hope so. Can you hear me?
Yep.
Okay, good. I just still see you in my little screen, so that's great. So I'm speaking this morning about what is clinical research, and clinical research for all of us is different than laboratory research. We all have pictures of people in their white coats. Why don't we? They teach us about molecules, about cells, about organs. Clinical research is the research we learn from humans themselves, from people. So this is a definition I found that I thought covered a lot of what happens in the BPREP program. Research conducted with human subjects, so people, usually to answer questions about diseases, their biology, their behavior, and the effectiveness and side effects of strategies intended to prevent or cure them. So that could be Dr. King in the center thinking about all of the questions. She didn't have glasses, but she had the right hair. Next slide, Terry. So what kinds of questions are we thinking about in BPREP? And there are many. So we've heard this morning about questions related to interventions like exercise, about genetics. Some of the questions that have been a special focus of Dr. King's research and about the program have been, what about some of these lesions that are found, atypical hyperplasia or lobular carcinoma in situ? So as researchers, we might want to know, what are the molecular features of these lesions? How can we best estimate the risks of developing breast cancer associated with finding them? What is the best way to estimate that risk for women? Is it combining all their risk factors? We ask everyone to fill out a questionnaire every time telling us about risk factors that might modify these risks. And we have to incorporate as well the findings of these lesions on biopsy. And how can we figure out who will benefit most from the interventions that we have to offer? So we have medications that we know can reduce risk, but for any one person, we're not very good at saying that we can be sure that one intervention is better than another, or that all, will likely work. We need to know who will benefit and who will have side effects, and how can we prevent them? And then even monitoring questions: who should be monitored with mammograms? Who should get breast MRI? Who should get both? Who should get ultrasounds? There's an unlimited supply of questions. And when people come to the clinic, they expect us to have answers. And the answers that we have at this time have come from research that's been conducted up until now. But we certainly feel that it's a responsibility to try and increase this knowledge so that we can better take care of the women who come to see us. Next slide, please. So you can, I didn't realize that was animated. Yep, it's okay. You can advance and show this. So this is a little joke slide, but it's meant to think about the question, what kinds of genes affect the development of breast cancers, and can we target them? So on the left is the appearance of a breast cancer under the microscope. And certainly all breast cancers don't look the same, but they do not look like the image on the right, although that is a mutant gene. It has a third leg. So that's a little joke. But there are ways to molecularly study the genes in cancers. We don't use them so much in precancers, although there is a big national project called the Precancer Genome Atlas, where researchers are studying early lesions to see if they can characterize some of the molecular underpinnings or the drivers of the tumor development from these pre-malignant lesions. If we could do that and we could take a piece of tissue from biopsy, we might be able to figure out how to block the development of cancer from these cells. Next slide, please. This is something that you see similar to this, at least in the material you fill out in the clinic. So you answer all of these questions about risk factors and lifestyle, and we do get an image at the end that has sometimes a pedigree and some risks that are in this slide, the personal risk in red for this woman and the population risk in the dotted line. So the numbers are not made up. They come from models that have been developed through other research to try and estimate what is the risk for this individual compared to the general population risk of breast cancer. And you can see that for this woman, who would have been 47 at the time that this was filled out, And had she lived until 82, which is 35 more years, the chance of getting breast cancer in the general population for her would be about 10%. So we usually say 12%, but of course that starts a little younger. And then in this woman, the risk is much higher. Now, the way that this graph is presented, it doesn't go up to 100%. Maybe it would look a little bit less impressive, but it does still show that this woman has higher risk. These figures are based on a lot of research that's gone before, trying to ask about risk factors that are somewhat reproductive, like the age up above, when did her period start, that's menarche, or when did she have her children? Because of course, most of what we know about breast cancer development is based on hormonal events in a woman's life. So we ask those questions and we ask them all the time, even though we know they don't really change from time to time. And then we think about genetic factors. So these models help to estimate risk, but they're models, and models are estimates, and models can always be improved. So part of research might be to improve prediction models. Next slide. So I said that this is about hormones, and as women, we're all looking forward or backward to the days when the hormones changed on their own. Then we worry often, is it safe to take hormone replacement or supplementation? Can we tell our daughters to take oral contraceptives? Is that safe for them or for us? What about other kinds of hormone supplements? What about hormones given when one is younger? What about later, after menopause? Many quality of life questions are wrapped up in hormones and in hormone blockade. So we have drugs designed to reduce breast cancer risk that either block estrogen, like tamoxifen, or block the production of estrogen, like the aromatase inhibitors. We certainly have focused a lot on estrogen, and these drugs work, but as we know, they have side effects. So the point of much of the research is to figure out, are there better ways to try and block or adjust hormones and still optimize the way a woman might feel while reducing risk? So we had a study of tamoxifen gel. So tamoxifen is well known, has been proven in very large prevention trials. Randomized studies are standard of care where half the women got tamoxifen and half did not. And we could show that 20 milligrams of tamoxifen a day not only reduced breast cancer risk in half, but that the protection lasts 20 years. So 15 years after you stop tamoxifen. Sounds great, but most women don't really want to take tamoxifen because of the side effects. So we have recently had data on 5 milligrams of tamoxifen in a study done in Italy. That is, interesting, but not yet necessarily definitive, but certainly encouraging. And we recently had a study of tamoxifen in a gel that was a lower dose given right to the breast that could also reduce the absorption of tamoxifen, so hopefully the side effects. So we all know that we can reduce breast cancer risk, but our strategies are not necessarily perfect, let's say, for everyone. So we have to find newer, better ways. And a lot of studies are about trying to adjust the risk of breast cancer once we're able to estimate it. Next slide. So what about early detection? So we talked before a little bit about screening and mammograms and MRIs, ultrasounds, some of their limitations. They do work. In studies for mammograms that have now gone on for decades, we know that we can find early breast cancers and reduce breast cancer risk. But there has to be a better way. None of our techniques work as well as they should. Next slide. So I thought I would try a little bit to talk about some of the progress and research, but also just to show you some images in case you're someone who's never seen what any of these things look like. And I should qualify this completely by saying I am not a breast radiologist or breast imager. Fortunately, at the Lee Bell Center at the Brigham and at Dana-Farber, we have expert breast imagers to work with us to make sure that, that we're not missing things and that all the necessary biopsy techniques and management options are available to our patients. So first, Terry, if you'll just advance through these. So this is just a mammogram image, so you get an idea. Mammograms have improved, fortunately. The addition of tomosynthesis has made the mammograms more accurate, particularly in women who have more breast density. But we all know that mammograms miss things and make mistakes. Here is a breast MRI. And of course, you really can't compare these two images. They're not the same person. These are just images from the web. But you can see that MRI does, because of that gadolinium injection, make it easier to see that bright spot. In this case, looks like it's on the right. And so these are ways to make it harder to miss things. But we know that MRIs have as their problem that they can be too sensitive. You can see lots of little spots on this MRI. And I'm sorry, somebody in my backyard is doing some work. You may hear it. Not my backyard, some other backyard in the next door. But anyway, that it makes it easier to see things, but some of them will be overcalled. They'll look like cancer. We have to make sure they're not more biopsies. I can't believe this is happening now. I hope it's not too hard. Next slide. Yes. So this is an ultrasound, and it's great for people like me when it comes with the arrows drawn in by the radiologist, so I can see the cyst that they identified on this image. Ultrasounds are helpful, usually for telling the difference between solid and liquid collections in a mass, and we use them all the time in people who've felt something to try to start the evaluation. But they're challenging for screening because you have to look at the whole breast, and breasts are so variable that they depend very much on the technician and the radiologist, but they certainly have a role. And we never used whole breast ultrasound before. We're learning to use it now. Now there are new techniques that are under study. First is contrast mammogram. So you have to kind of, in your mind, look at the difference between this and the one at the top. But this is giving the injection during the mammogram instead of giving an injection like you do in the MRI. And this too can make it easier to see a lesion or a finding in the breast. And these are under evaluation now. And rapid breast MRI didn't have a picture for, but that's because we all understand that lying on your stomach in that weird position in the MRI machine takes a long time. In the rapid version of this, it will take less time, but you still need that gadolinium injection. And at the bottom, since these are all techniques that are still having some evaluation, these last few, this is using artificial intelligence to improve the reading of mammograms and possibly to identify the spot in the breast where cancer may develop, which would help the radiologist too. And you can see this very cool red and green spot, which is obviously not a real spot. It's created by the computer by looking at the images, trying to identify a very subtle collection that could be a tumor, very hard to appreciate in the image to the left. Artificial intelligence is not robotics, and there's nothing scary about it. It is just using computers to try to help radiologists see better. And this is something being examined in research, both in imaging and in pathology. If we've got computers, we ought to use them to help us be smarter. Next slide. So what else do we know about what reduces breast cancer risk? Well, you've heard a number of really excellent talks this morning talking about this. We have lots of possibilities for breast cancer. We have great talk on exercise. Weight reduction gets a little harder. There are proven medications, and there are medications to be studied. On the right was just a graph to show you that we actually do have evidence from people participating in clinical trials that interventions make a difference, that in blue, in every pairing, you can see blue above red, more breast cancer in people who did not take tamoxifen. So just to show that we don't make these recommendations based on logic, we make recommendations based on data, and therefore we try to collect the data ourselves to move the field forward. Next slide, Terry. So what is the SEARCH study? Many of you will have been or will be approached about participating in SEARCH when you come to the BPREP clinic. And so the SEARCH study is a study. It's a research protocol that is there for the systematic collection and organization of data, in this case, about patients at increased breast cancer risk. So it helps for us to learn as much as we can from each patient to help others by improving our ability to collect, to predict going forward, or to think about designing interventions for risk reduction. And what does consent mean? Well, so I said at the bottom that protocol and consent are approved by an independent body. That's called the IRB, or the Independent Research Body. This is a group of individuals from in this case, from the hospital, from the university, also members of the community. IRBs are not just researchers, they're also regular people who look at the materials to make sure first that the research has merit and value and is going to lead to an answer. That's among the first criteria. And then that it is adequately explained to patients in the informed consent document, that by looking at this, you actually would know what the research was about, and that we have communicated clearly also in the document that everything about research is voluntary, that you always have the right to say no to any or all of the components, and you have the right to change your mind. And all of that is in the consent document. Consent is considered a process. It's a discussion between you and the researcher, or you and the research staff who comes to talk about this. So you have the right to ask questions, and you should sign when you're ready and know. But in the search study, the goal has been, as I said, to learn as much as possible from each person seen in the program. But research allows us to do that. So of course we can look at your medical records to take care of you, but to be able to use them for research, it's best if you sign a consent that lets us do that. And that is for us a promise to you that we will responsibly use them for research, that they are not just collected, put out on the internet. They are stored in ways that have been designated to be sufficiently protective, that we protect your privacy, but yet still can use the information without identifiers, so no one could trace it back to you for research. That if you've had a biopsy or breast tissue collected either from surgery or from the radiologist, that we might be able to take some of the tissue left over after the pathologists have finished with it to look for some of these molecular points I talked about. We might ask you to give a blood sample because we are interested in genes, but not necessarily the BRCA1 and 2 genes, maybe other genes that modify how you might respond to various interventions, or that might have contributed to your breast cancer risk, just not as strongly as a gene like the ones that Fatima discussed. You might answer some questionnaires, so you really fill one out every time you come, but this allows us to use it for research with the same protection. And we often ask if you would mind being contacted if we have something that comes along that might be appropriate for you. So all of these things are optional. I think we ask about each of them individually, but this is the goal of the work. Next slide. So this is from a different study, but it just reminds you that the way most studies are done, you register, you give your consent. Sometimes you get tested and get results. In most of our studies, you won't get results because it's going to take a long time to sort them out. And follow-up is important. How do we tell someone how much significance any factor is in determining risk without time? And time is the problem. As researchers, we're impatient, but what we have to figure out is what happens over time. And that's part of why we try to stay in touch with people in the program. We want you to be followed with us so that we can learn, did the tamoxifen help reduce your risk? Or at least what happened? Did you get breast cancer or not? What happened to images? What happened to imaging changes? What happened as the technology itself advanced? So just as Dr. King has really made part of the program having an ongoing commitment to the care of patients, we are also committed to research over the long run. Next slide. So lots of risks and benefits to consider, all of them from the exercise programs that you heard described in such clear detail to the genetics. They're all based on research, so we can provide information about risks and benefits. And for you, clinical research is an opportunity to give back a little bit, I guess, but to help generate new information that might improve information that you need to make decisions going forward. And someday I'll find a slide that has someone in the back behind the counter who looks more like Dr. King than that W little guy. So.
Thank you very much, Dr. Garber. Hopefully you'll find a better slide and I won't start to look like that person behind the counter.
More exercise, I'm not concerned.
All right, so thank you. That was a very nice recap of a lot of the things that we touched on this morning, really highlighting that it is clinical research that allows us to learn from our patients and then give back the information to our patients. Since you did bring up the future of artificial intelligence to help us read mammograms, I do just want to highlight for everyone that at our forum last year, Dr. Connie Lehman the chief of breast imaging at Mass General. She gave a really nice talk on artificial intelligence use and mammograms, not only for detecting cancer, but for also predicting risk. And that is available on our website. You can see her talk from last year, as well as other talks from last year there. And as we said at the outset, we will get today's program posted on the website as quickly as we can as well. There were